In Chapter 7, we will look at safe medication administration and some of the things you can do to ensure that you are safely administering medications to your patients. You need to be aware that in any agency that you work in, there will be some type of medication administration record, or MAR. This may be electronic, that's the trend that we're going toward, or it could be paper. Every facility has their own specific MAR, but most of them are going to have the same types of things on them, which we'll discuss. Here are some of the things that they have in common. There's usually a large column on the left-hand side that contains the drug names, and oftentimes that can be either generic or trade name, or it may have both. It will also have both scheduled meds and as needed or PRN meds. It will have the drug dosage and the frequency of the drug administration. For example, it may be to be given every 8 hours or 3 times a day. Whatever the order is will be listed there as well. There will be a place for each shift to document their medication administration for that shift. There may be a place for documenting precautions such as a pulse or a blood pressure or a body weight. For example, if you're giving an antihypertensive, there may be a space to document what the blood pressure was at the time you are giving it. If there's not a place on the MAR for this kind of information, it can be documented in the nurse's notes. Almost always we initial the medication as we give it, and also we will initial, if we are transcribing the medication from an order sheet to an MAR, we'll be initialing that also. It may also include start and stop columns indicating what day and time the medication is to be started and stopped. For example, some antibiotics are ordered for a certain amount of days, so you may have a start and stop date on it. Some narcotics have to be stopped after a certain amount of time and reordered. Because we usually use our initials to document when we have given a medication, there will be an area where your initials will be identified with your full name and title. The MAR may be 1 sheet or 2 sheets, one for, say, scheduled meds and one for PRN meds, or it may be, again, electronic. Here's an example that I took out of your book of an MAR. They all look fairly similar to this. You've got here your start and stop time. And this particular one only has the date. They're all started on May 1st. In this column right here, you've got your name of your medication, the dosage strength, and also in this column you've got when it is to be given right here. And you can see that they have put in that you're to daily check the pulse right here. Also, you've got the route that it is to be given right here. Whoops, I didn't quite get that. And then this is the nurse that transcribed that particular order. In this column right here is the actual record of when the medication is given. And you can see this one is given at 8. And the top box is the time that it was given. The middle box right here is the site. So if you were giving a, say an IM injection, you might put LT in one of those boxes for left deltoid. and then the bottom is for the nurse's initial that is administering it in this area right here. The second example right here, it was given at 8 and 4. And again, those are not documented until the nurse actually gives those medications. Then you can see down at the bottom, you've got a column for initials so that you can identify these initials up here and who those initials belong to. The signature goes down there. We've already gone over this in foundations, but again, critical for you to know the 6 rights of medication administration. You've always got to make sure that you've got the right drug, the right dosage, the right route, the right time, the right person, and the right documentation. Your book talks about a 7th right, and that is right collaboration with the patient. So in other words, if you take a pill in and the patient says, I don't usually take that pill, you need to listen to your patient and go double check and make sure that they are supposed to get that pill. Typically patients know more about their medications than we do, and so it's really important to listen to the patients. When you go in to give a drug, you want to check that drug 3 times. This will help eliminate errors. One is when the drug is located. In other words, when you get that drug out of the drawer or out of the Pyxis or whatever system that your hospital is using. Also, the second time is just before you open it or pour the medication. And then the third time is immediately prior to administration. It's also important to compare the dose that you're giving to average doses. Now, after you give doses for a while, you'll come to know what an average dose is. Until then, or if you're giving a drug that you're not familiar with, that's why you look in your drug book or the insert that comes with it, so that you can actually calculate what an average dose for a patient of your weight or age is, so that you can make sure that the dose you're giving is appropriate. Also, metric dosages that contain decimals are of particular concern, and we've talked about that before. We want to make sure we have the 0 in front of a decimal and no trailing zeros because of the problems that can cause and the errors that can cause in misreading those medication orders. You always want to check what route it was ordered by and that that is an appropriate route that this medication may be given by. For example, oral, sublingual means under the tongue, drops, where do the drops go? Is it in the eye? That would be optic. The ear would be otic, or nose, nasal. And then there's topical. It could also be transdermal in the form of a patch, inhalation, which could be many different ways, either an inhaler or it might be a breathing treatment that is given by a small volume nebulizer, creams or suppositories, which of course would be rectally. It may be given by a parenteral route, and those include IV, IM, which is intravenous and intramuscular, subcutaneous, or intradermal. We talked about all of those in class the other day. We also want to make sure that we're giving it at the right time. Some agencies use standard time, some of them use military time. For standard time, 12 a.m. is midnight, then you go all the way to 11:59 p.m. for 1 minute before midnight. The times are duplicated during a 24-hour period. For example, you have 1 p.m., 1 a.m., and the a.m. and p.m. are the only thing that differentiate. Then you have military time. 0001 for 1 minute after midnight to 23:59 for 1 minute before midnight. The advantage of this is there's no duplication in the numbers, and it's virtually impossible to get AM and PM mixed up. You'll see I've put in a slide on the next slide, a comparison. Okay, wasn't the next slide, it'll be the slide after this. After 1 o'clock in the afternoon, 12 hours are added each time to each time until midnight. For example, 1 p.m. is, you add the 12 hours to it and you come up with 1300 right here. 5 o'clock p.m., you add the 12 hours to it, and that would be 1700. 10 o'clock at night, 10 p.m., you add 12 hours to it, and you would come up with 2200. And here's a comparison chart for standard and military time. Most agencies these days do use the military time. It is much less complicated, so you would be wise to go ahead and memorize this if you haven't done so already. It's absolutely critical that you give the medication to the right person. You want to check the ID band. You want to read both the first and the last name, plus you want to have them give you their birth date. This is now required as a double check. So you want to do that every single time a medication is given. Doesn't matter if you've taken care of them for 5 days in a row, you still check the ID band for name and birth date every time you give a medication. And then the last thing is the right documentation. You don't do this until you have already administered the medication. You don't ever record it before it's administered. Patients can refuse it, or something can happen and it doesn't get given. And so you don't want to record before, but you go do that immediately afterwards. Of course, with the electronic medical records now, you are doing it right there at the bedside and recording it. MARs are an immediate reference for medication administration, so the next shift can come in and see what was given. A physician can look at the MAR and see what was given, and it does need to be maintained up to the minute. As we discussed before, you want to partner with the client or the patient. If they question a medication, you need to double check yourself. They also have a right to refuse medication. If this is the case, you document that they have refused the medication, and if they give a reason, you can document that as well. It's estimated that 100,000 people die each year from medication errors. That is tragic. It occurs during prescribing, so when the doctor is writing the order, transcribing, in other words, whoever transcribes it onto an MAR, calculating, that's typically, that can be the physician or the nurse, and administering, and that's usually a nurse's job to do that. I think the thing to remember is that even if an error occurs in prescribing or transcribing, it is the nurse is the last line of defense before the patient gets it. So if the nurse is double checking and making sure it's the right dose, they can prevent any error prior to administering it. Also, another thing that causes a lot of errors are abbreviations, and the Joint Commission has put out a do not use list for that very reason. A lot of these that we no longer use used to be confused with other things, and it would cause medication errors. So instead of U for unit, we're going to write unit out. IU we write out international unit. QD in any number of forms there is no longer used. We're going to write daily. Here's some more. QOD, which means every other day, is written out as every other day. MS, you're going to write out morphine sulfate. MSO4 or MgSO4, you're going to write those things out, magnesium sulfate, because they can be so easily confused or misinterpreted. And again, I know that you've heard this many, many times, and you'll probably keep hearing it. We're going to omit trailing zeros, and we're going to use a zero before a decimal number. Those are two critical factors in eliminating medication errors. You can go to this website for a more extensive list of error-prone abbreviations, but the ones that are in your book and that we've gone over here are the most common ones that were used that we no longer use. Here's an additional one, and this would of course be true for no matter what hour it was. You're going to write the drug frequency instead of Q2 hours or Q3 or Q4. It's going to be written out every 2 hours or every 3 hours. This is the Joint Commission table that is in your book, and again, this is just a compilation of what we just went over. Again, when we are transcribing medication orders, we're going to not use trailing zeros. We will eliminate those. We're going to make sure that we put a zero in front of a decimal fraction. So it would be 0.5. And then illegible prescriptions. If you are in doubt about a physician's handwriting, then you need to double check and you need to call the physician and get it clarified. Unfortunately, medication errors do still occur sometimes. So what do we do when we have a medication error? Well, first of all, you need to report it as soon as it is discovered. You need to call the physician and make sure that they're aware of it. You need to institute necessary remedial measures immediately. In other words, if you've given an overdose of an antihypertensive, maybe you gave 2 tablets instead of 1, you're going to be needing to check that patient's blood pressure every 30 minutes or so until you know that the patient is not going to have an ill effect from that. You need to determine the reason for the error. Did a nurse forget to write it down? Is the MAR confusing? What exactly caused the error? You will have to prepare an incident or an accident report. That is separate from the chart, and these never, ever, ever go into the patient's chart, and they are never documented that you did those in the patient's chart. That just alerts any defense attorney that there is an incident report, and then they are able to get those. Those are for in-house to have a record, for the agency to have a record of the incident. And then you're going to institute corrective policies or procedures to prevent the recurrence if possible. Once you determine why it occurred, we don't want it to occur again. So we try to institute whatever needs to be done, a policy or a procedure, so that it does not happen again. 2 of the biggest factors in medication errors are you're distracted. You've got lots of things going on. You may have another nurse asking you questions, and you just get distracted. Even the patient can be asking you questions if you're at the bedside. This actually happened to one of our former students. They were supposed to be putting potassium chloride in the IV bag, and instead gave it to through the IV line, and the patient actually died. So do not let yourself become distracted. Also, fatigue is another factor. You've always got to pay close attention. And once you get comfortable with giving meds, it can become very routine, and distraction and fatigue are two things that can lead to errors, maybe even more so than when you're not comfortable with the process. Always use the 6 rights of medication administration, and I think I just said that. Routine medication administration should never be routine. Just mentioned this earlier. The MARs are the place to go when you are needing immediate information about what a patient has received or needs to receive. And another thing that you need to keep in mind is, regardless of the source of the error, whether a physician wrote a wrong order or pharmacy put something on the MAR that shouldn't have been there, or it was transcribed erroneously, you can be held legally responsible if a wrong drug or dosage is given. So it's really critical that you pay very close attention to what you're doing during medication administration.